So, hello everybody, delighted that you're here. And because Dr. Bransfield is answering questions today anyway and not sharing a PowerPoint, it's a pity, but not the end of the world that we can't see him. Martin is working in the background and maybe we'll be able to fix it. But I'll just introduce him to start with, which is that Dr. Robert Bransfield is a board certified psychiatrist with the American Board of Psychiatry and Neurology. He's clinical associate professor at Rutgers Robert Wood Johnson Medical School and also works in private practice. He's held teaching appointments at Hahnemann Medical College and Eastern Virginia Medical School. He has a particular interest in psychopharmacology, a unified theory of mental health and illness, and the link between microbes and mental illness. So we have a lot of questions today that have come in previously, so we'll start with those, if that's all right, and then go on to the ones that you're asking live in, please, the chat below or the Q&As, please. So first of all, Dr. Bransfield, any updates? How have things been going over in the US? Have you noticed in particular that a lot of patients are getting sort of relapsing, remitting symptoms after having COVID if they've had Lyme previously or other tick-borne infections?
Well, I do see there are some patients that are relapsing, remitting, sometimes weeks or months with COVID. Now, when you have COVID and Lyme, I had a patient, actually I had two COVID Lyme patients yesterday. And one, since he had COVID, he had a relapse of his Lyme symptoms and he just hasn't come back. And he was not under treatment for anything when that happened. And another one I had yesterday, he really was quite ill. And I started him on the hydroxychloroquine and that turned him around, I think, with the severity of his symptoms. He was having trouble breathing.
Oh, wow.
And I think it was life-saving with him. And he is much better now. So it's, you see quite a spectrum. And I do think that many, overall, I'll go with my initial impression that overall, many of the treatments for Lyme seem to have some protective effect against COVID. And Dr. Stricker did an article on this, a peer-reviewed article, where he addressed that issue, that out of all his Lyme patients, they all did well, the ones that were under active treatment. And I found that to be the case. And even with different treatments, whereas the patients who have Lyme that were not under any active treatment, they were the ones that were more likely to relapse. And that was one of the cases that I had yesterday.
Okay.
And that reactivated his old Lyme symptoms, which before he had the COVID, he was doing quite well. And he had a rough time, but he was treated, and then he had finished treatment and he was back working and doing well, but then the COVID hit him, and now what he has isn't so much, he doesn't have residual COVID symptoms or recurrent COVID symptoms. He has recurrent Lyme symptoms. So he's back to square one with his Lyme symptoms. That's what I've generally found. Although I did find a couple exceptions where a couple people that had high fever when they had Lyme, when they had the COVID, those people, it almost seemed like having COVID helped their Lyme. The high fever may have treated their Lyme in some way and improved their Lyme. So there's those three patterns.
Oh, wow.
The people under treatment usually do okay. The people that are not under treatment might relapse with their Lyme symptoms. And then there's that third group where a couple people that get the high fever, it almost seems like it's therapeutic to the Lyme disease. Those are the three groups that I can identify so far. And I'm looking at what other people are sharing, and I'm seeing somewhat that pattern too from other physicians and other discussions on the internet.
Okay, thank you. That's fascinating. Well, I'll go through the questions we've received. A lot of them aren't specifically relating to COVID, but Lyme and co-infections. I hope that's all right.
Sure.
First of all, because you have just mentioned hydroxychloroquine, one question is, how do you feel about the immunosuppressive effect of hydroxychloroquine and corticosteroids when treating Lyme or COVID?
Well, the corticosteroids you would not give early. So that's something you would give late. And you have to look at treating these things. For instance, with the COVID is pre-exposure prophylaxis, recent exposure prophylaxis, and early treatment, and then late treatment. You have to think of all four of those categories differently. So could you repeat the question again, because I kind of got off?
Well, how you feel about the immunosuppressive effect of hydroxychloroquine, if you feel that there is one, you might not have encountered that, and of course corticosteroids when treating Lyme or COVID.
Right. Well, certainly the corticosteroids, that's a risk because you don't want to reduce inflammation. You want some inflammation in early treatment. And that is one of the effects of the hydroxychloroquine, but it seems like, although that may be a positive in later treatment, possibly, it could be a negative in early treatment, but you're relying more on the other therapeutic effects of the hydroxychloroquine in early treatment. You want that early response. Now, one thing that seems to be interesting with this immune response is that some people get an early T cell response who just have a natural resistance to the disease. And those people are people that are just resistant to getting infected. And that's very significant when we talk about herd immunity, because there's some people that get infected and then develop antibodies, and that contributes to the herd immunity. But the people that have that innate T cell resistance to the infection, those people also add to the herd immunity. And those two groups added together seem to be quite significant. So it is very hard when you look at hydroxychloroquine, because there's all these different effects it can have.
Yeah.
And what are the effects that are more significant? And that's divvied up in early and late. Like there's 50 some articles looking at hydroxychloroquine. And when you break that down, there's good evidence it's preventative. There's good evidence it's good for recent exposure. There's good evidence in early treatment, but the evidence in late treatment is very inconsistent and questionable.
Okay, thank you. Another question here. Do you use corticosteroids for Lyme patients who show signs of HPA dysfunction?
I don't, but I know some doctors do for like a very low dose. Mm-hmm. And what I do instead is my basic assumption that growth hormone is the master hormone for HPA functioning. So if you promote the delta sleep, the deep sleep, that tends to increase the growth hormone, which can impact not just your corticosteroid, but the sex hormone, thyroid, everything. I think that's, looking at a domino effect, that's taking it back further. And I find that to sort of achieve the same thing from a different angle.
Okay, thank you. And one last question from this group here. Have any of your patients had success with atavaquone, that's Mepron, or nitazoxanide, which is also called Alinea?
Yes, particularly Mepron. That seems to be as good. A number of these anti-malarial drugs seem to work. And Mepron is used. It hasn't been politicized. There isn't some politicians have obstructed access to it. And that would work just as well. It's not well known, it's not popularized. That seems to be quite effective.
Okay, thank you. I'll just read this one here as it is. It's quite a general one. What do you advise patients with chronic Lyme disease who are struggling to cope with severe anxiety and stress, please? I know that's very, very general, but maybe just a few tips there. Do you recommend GABA, for example, this patient is asking? Or is that just too general to get a handle on? Dr. Bransfield, are you still there? Martin, I think we might have lost Dr. Bransfield.
Okay. I have no idea what's happened.
Could you give him a call, maybe?
Just a minute. Okay.
I'm sure he's going to try and dial in again. Sorry about that. We'll have him back again in a moment, I'm quite sure. You have his number, Martin, or shall I give him a call?
I'm calling him.
Great, thank you.
Let's try another one.
Hi, I'm back. Okay.
Oh, hello.
Good.
Hi. Yes, you
Yeah, I
dropped
lost
out for a moment there.
I lost my connection for a minute there.
Oh,
okay.
sorry.
All right, so the stress, your problem is that I think when you get Lyme disease, it makes people more stress reactive and they get more hypervigilant, hyperarousal. They'll often say, I never had all this anxiety before. Now I'm hyped and anxious and that never happened before. You also have like a sensory overload that people are very reactive to things around them and they get flooded by sensory input. That adds to it. So you want to do things that tone that down. That's why a lot of Lyme patients like environments that are calm, peaceful, and not a lot of stimulation. And they can't tolerate the frenetic activity locations like they used to be able to tolerate. So sometimes things that help focus can help because then there's a little bit better ability to screen out that sensory overload. But a lot of your anti-anxiety type treatments that we use in psychiatry can help there. Because if a person is constantly in that state of hyperarousal, a lot of their resources will be consumed dealing with stress. And it's hard to fight a battle within if you're constantly stressed. And that makes a person somewhat more immunocompromised. And so anything that helps the anxiety level to be more in a reasonable level, which is basically most of your psych meds, sometimes your SSRIs or meds in that category.
Okay, thank you. This is about a medication sometimes used for PANS, which you'll know of. It's used a lot more in the States than here, and for pandas, IVIG. The question
Right.
is whether you've encountered this, that it's used in a low dose for Lyme disease, but in a high dose for PANS or pandas, and how to kind of reconcile those two if you have a patient who has PANS, pandas, but also has Lyme disease.
Well, to reconcile it, I think the way to look at it is you get an infection, and ideally you get early inflammation, then adaptive immunity, and then you're fine. And with pandas, you get usually some other infection, and then you get that autoimmunity instead of adaptive immunity. Now with Lyme, you can get some of both, where you get that infection, you get the early inflammation. The early inflammation persists because you never get adaptive immunity, but there's also an autoimmune piece in addition. So the IVIG does help with Lyme patients that have that autoimmune piece. And actually I had one case yesterday with that. And a lot of your PANS cases, you can see this very erratic, volatile, irrational behavior. The one yesterday was it was a child that would just suddenly had a violent outburst and sometimes jumping out of windows or doing things that are very bizarre and jumping and standing on tables, crawling under tables. It comes from nowhere, and it's it can be very explosive and of a sudden onset. But the IVIG does help with that. There are a few people that I've seen with that pattern where it's almost seasonal. So maybe there's a seasonal allergy piece to it. But these PANS cases can overlap with Lyme, and basically when they overlap, you see that greater preponderance of autoimmune symptoms as compared to the inflammatory-based symptoms, although they may have both.
Okay, thank you. A question here. There are other conditions, or rather, are there other conditions, not Lyme, which can also affect the brain and mental functioning, but which are recognized by medicine as infectious in origin and treated as such?
Well, the prototype originally was syphilis, and syphilis was the model for it. And but then once penicillin came out, people kind of forgot the infectious disease connection with mental illness, and got away from that. But this is, so that's why Lyme is called the new great imitator.
Yeah.
You could almost call COVID the third great imitator because of the complexity of it, particularly with some of the residual symptoms. So think of it this way, that evolution really is a rather perfect thing. And look at how the body's evolved, including the brain. And we have these adaptive circuits that it's like gear shifts in a car that help us adapt to different life situations. And since evolution has done a rather good job, why is there so much mental illness? It doesn't make sense. And most illness is sometimes developmental or deterioration late in life. But mental illness hits midlife. It hits early life. It hits teenagers, children, young adults. So that there's something different there. And what's it about midlife that's different? You have a more robust immune system. So it does seem like there's a very strong immune component to mental illness. And if you think of what gives an aberrant immune response, the number one thing on your list is infections. After that, allergies, toxins, and other things. You can work your way down the list, or deficiencies, nutritional deficiencies. But it does seem like a long list, and a long list, there are really thousands of journal articles showing a link between various infections and mental illness. So it's not just Lyme, it's not just tick-borne disease. There's toxoplasmosis, think of rabies, or, it's a very long list of these conditions, even viruses. And then it's sometimes more than one infection, so it's a complex interactive infection. And I think we have to realize that, a normal brain doesn't have all this illness, so something causes it. We categorize things with the DSM, but we don't address the cause. And this is the cause, and then it's mediated by the immune reaction, which in turn results in the symptoms.
Okay, thank you. This is quite a long question by a professor who I think you've often shared the platform with, so I will preface it by saying that his question is really, could you please comment on this and make any suggestions about how to facilitate awareness of this? So I'll begin reading it. It's now becoming apparent that Gulf War Syndrome, GWI, is being categorized as a chronic multi-system illness, along with ME, fibromyalgia, MCS, that's multiple chemical sensitivity, and others, including Lyme disease. GWI is now seen as a chronic neuroimmune disease with extensive disruption of cytokine and chemokine systems. And the provoking agents are usually powerful cholinesterase inhibitors, organophosphates, and so on. And there are also latent organisms such as DNA and RNA viruses, EBV, and so on, that are all activated in people with these chronic multi-system illnesses. So it goes on a little bit, but I think overall the question is, because vaccines can also provoke further symptoms in these individuals and chronic disabling neuroimmune damage, he writes. He's wondering whether you could comment on this and how to raise awareness of this, because often these patients are simply relegated to sort of the psychiatric category and given SSRIs and not a lot more. I think you'll
Well,
probably
a
find
lot
that.
of complex, chronic, costly diseases are just kind of lost, and people can't get a handle on them. They'll they'll categorize them wrong and say, well, these are subjective and non-specific, so therefore they're psychogenic, which is erroneous. And I addressed that in an article about psychosomatic versus somatopsychic illness. Now, if you look at, let's say, Gulf War, there were different facets to it, and it's interesting, with many wars, there's a post-war syndrome. We saw it with Vietnam, we saw with every war, pretty much. And you're exposed to things in war zones that are pathogenic. Now, there's different hypotheses with Gulf War. One was that people got all these vaccines in quick order. They get 12 vaccines in one day, or and then they'd be shipped over. And did that have a destructive effect?
Yeah.
Then there was the toxic exposure, where there were the fires and the chemicals there and the toxins that are part of warfare.
Absolutely.
And then being exposed to various infections agents, mycoplasma came up. Now, one interesting with the vaccines is there's been an observation that since we've had this shutdown and people aren't getting their regular vaccinations, children aren't going for the regular vaccinations, now we're seeing a reduction in SIDS cases.
Yes. Can we just spell out what SIDS means for those who don't know it?
Sudden infant death syndrome.
My goodness. Yeah.
Okay. So during this pandemic, when you look at fatalities, and when you look at the 0 to 2-year-old bracket, there's a lower risk of fatality in that group. Why? Okay.
Mm-hmm.
Now, is it because parents are home watching them more, or is it because they're not getting their regular vaccines, and that you have a certain mortality rate from these vaccines when you give so many vaccines clustered together? And so it's an interesting observation that many people are worried that now we're not having these regular vaccines, and this is scary, that we're seeing less fatality. So it maybe we have to rethink how we give all these vaccines in such a short period of time. Similar to what was the issue with Gulf War, that and particularly the anthrax vaccine jumped out more as more of a risk than other vaccines with Gulf War. So there's these illnesses that are hard for some people that do a sloppy exam to sink their teeth into. To do a proper exam on any of these complex illnesses, you have to go into great detail and take a very thorough history. You just can't go on a lab test that's a gold standard. There is no gold standard.
Mm-hmm.
And if you look for a gold standard, it'll be a fool's gold standard. And you have to approach complex emerging diseases that way. And when you don't do that, then you're going to do a disservice to the patients, which has happened with all these illnesses. And it is, these are complex illnesses that have many components, and you have to tease that out and look at those different pieces to approach it properly. You just can't use a simple model. And people prefer a simple model with one variable, and it just doesn't work for that. So that's the problem with these complex illnesses.
Absolutely. That really deserves a webinar all on its own, doesn't it? I think the evidence will continue building on that exact point you've just touched on. Another here, at the start of the COVID pandemic, health officials, certainly in the UK and US, said there was little evidence for the effectiveness of face masks, but now they support the use of masks. What are your thoughts on the positive and negative effects, if you'd like to go into that topic?
Well, initially they were saying don't use face masks because we want to save them for the healthcare professionals. Mm-hmm. And I think because of that, there was a promoting to the public to not use a face mask because we need them in hospitals. Now, there is controversy surrounding the face mask. And we've certainly used face masks in medicine for decades. But for instance, somebody did a put a face mask on and they did an oximeter, and they put it on their finger before the face mask and then afterwards, and their oxygen levels dropped quite a bit.
I saw that too.
So can face masks give hypoxia, which isn't good? You exhale certain things you want to get rid of when you exhale, and you're breathing your own air back and forth when you have the face mask. So there may be a contamination there. Now, when you look at, so I think in all probability they help, but you just can't be absolute. You have to look at all the pros and cons that people sometimes raise. It does give a feeling of confidence when a person has a face mask on. I think a value of a face mask is if I'm in a supermarket and I sneeze or I cough, it may be less likely to spread it out in the air where it may harm, infect other people. And that maybe that's more useful than preventing me from inhaling something else.
Yes, having a differentiated view on it. Yeah.
And are these particles, these particles may be too small. Are they really caught in the face mask?
Yeah.
And so it's, we're using it. China did this for years. Whenever you would see pictures of China, a lot of people wearing face masks walking down the street. I don't think it's unwise if you're jogging or riding a bicycle or outside in a somewhat non-crowded area. And I think it's more questionable about outside.
Yeah.
So it's not an absolute thing. So I think you'd want to look at all the pros and cons objectively, but some people are rather rigid about it. And it did get politicized too. If one politician says yes and another one says it's no big deal, then that gets a political overtone that contaminates the scientific argument.
Yeah, and deciding where you wear them is probably the most important thing, isn't it? There's an article in the papers today here in the UK. New Jersey driver crashes car after passing out from wearing an N95 mask.
If I wear a mask, it fogs my glasses and it obstructs my vision. So I'm afraid to wear it when I'm driving a car.
Exactly. No, he passed out from lack of oxygen, so that was
okay.
Obviously not a good.
That's like the oximeter test, and anybody can do that. They can do an oximeter, and you should have this for the COVID. You see what your normal oxygen level is in your finger, then put the mask on and see what happens. Does it drop? Is that a significant drop that maybe is threatening?
Yes. I'll just ask one more from the questions that came in earlier and then go on to the ones that have just been asked. You predicted rioting when you spoke last time. What triggers this behavior and what can be done to restore peace?
Well, I think when you shut down a society, that it gets people frustrated, and you particularly see this during the summer months. And you see more suicides, you see more frustration. I think particularly children and young people, their sporting event is a way to channel aggression and frustration, and they really need that social effect. I think people that are older, established in life, it was not so traumatic as it is for children, teenagers, young adults, that being stuck in social isolation bottles up a lot of frustration, and then I think the other part was the economic impact. The people that are out of work and not paying their bills and socially isolated, it leads to an increase of distress or diseases of despair, we would call it. But some people show diseases of despair by being suicidal. Some show it by being violent. Some show it by becoming physically ill. And so I think we're going to, if prolonged shutdowns, I think will fuel violence. And
Absolutely.
the longer it goes on, the worse it would be. And it's a concern. It's very disruptive to society to be in such an unnatural state.
Right, thank you. One question here that's come in just recently is, I've heard that on an American military ship, COVID-19 did not spread as expected. It was claimed that the MMR vaccine had protected them. Did you hear about that at all?
Yeah, well, it's on you know, there was the ocean liner, and then there was the aircraft carrier. It was interesting. And I think there, probably the recirculating air, the HVAC, it was a big thing in spreading it. But the MMR, that I didn't hear it about the ship, but I heard about it with America's Samoa. And what they had an epidemic there, and everybody there had been recently vaccinated with the MMR.
Mhm.
And now they say, well, there's no COVID there. So it looks like there's some protective effect maybe from the MMR. Now, people also speculated about with tuberculosis, you know, shot, but they also with a polio shot. And that was an article about a month or so ago, where the theory is that maybe the polio vaccine has some protective effect. Now, we think of repurposed drugs for therapeutic effects. This is looking at repurposed vaccines
Mhm.
that might work, and there are vaccines for some other illness that may have some protective effect here. But those observations with MMR and the polio, but the MMR seems to get more traction, and maybe there's some other vaccine. But that's interesting. If we can have a vaccine already we know is safe, maybe that's a vaccine strategy that has been overlooked.
Right, thank you. And then could you say something about disulfiram therapies and interaction with COVID-19 infections, if you have any experience there? Or
Yes,
thoughts?
I've had a number of people on I have a fair number of people on disulfiram treatment. I did a video on this. It's on YouTube somewhere. And what I found is the people on disulfiram treatment did quite well. It has a protective effect. Now, if you look back, there's two journal articles, and one looked at it that it's a protease inhibitor with both SARS and MERS. So it does have some protective effect there. So there's a physiology that makes sense. And but in terms, you know, what happens in a test tube can be what happens in different life. I had a patient, and he had 7 family members there, and they were all sick, and he was on a disulfiram, and he felt he got it a little bit, but it was a very minimal degree. Another patient who had it, his whole family was sick, and in both these cases, people in their neighborhood were sick. These were high-risk neighborhoods, and everybody in his family had it, and he didn't get it.
Huh.
So it does seem like, by clinical experience, that disulfiram, both from the test tube data and from my personal experience, it has a protective effect at preventing or at least buffering the severity of the infection.
This may be difficult to ask, but a question has now come in whether the dosage for that is different to the kind of dosage that people have been using for Lyme disease, or is it too early to say?
Well, it's hard to tell. I think the people that I found were protective, those were individuals that have kind of worked their way up to a little bit higher dose, like 125 or 250 a day. Whereas when you start with the disulfiram, you start much lower. And would a low dose work? Maybe, but it's I don't have experience with someone being on a very low dose and being exposed. But I don't think, none of my disulfiram patients had difficulty with COVID.
Okay, that's very interesting. Some people think that ivermectin helps with COVID. Do you have any experience with this?
Well, it seems like there's rather good data. They're using that in Asia. It's in Bangladesh. They're using that. They're using the ivermectin with doxycycline, and they found that was quite good. And it comes up a lot. It's also on the EVMS protocol as a early treatment and as a prophylactic treatment. They're studying this at the University of Kentucky for prophylactic treatment. They're looking at ivermectin, hydroxychloroquine, and then there's a third arm, which is a drug for a pancreatic drug out of Japan. So we're seeing that. So I think maybe now ivermectin has a different mechanism than hydroxychloroquine. Maybe it might be a cocktail of ivermectin hydroxychloroquine, zinc, D3, A, C, even melatonin. These are, and some other things are candidates for preventative treatment. And I think that's really where the money's at, is you taking these preventative treatments and being functional, and that way you're not destroying your economy or your social structure by the social isolation.
Right, and Dr. Horowitz spent quite some time talking about glutathione when he was on with us the other week, and said that he'd found that extremely useful, and that's not being covered by a lot of different doctors, interestingly. What's your experience there?
Right, although I think you'd add to that list of N-acetylcysteine, which is basically glutathione.
Mm-hmm.
And if you look at that cocktail, yeah, let's add NAC, and NAC is really used a lot with some psych conditions. And there's even evidence, test tube evidence, that a couple of the SSRIs work. Fluvoxamine, which is Luvox and Prozac, there were evidence of both of them, and even a couple of the tricyclics and a couple of the antipsychotics. Those were like some of these high throughput screening testing showed that.
Okay. Could the anxiety and sensory overload that you mentioned earlier be due to an element of atraumatic brain injury following severe illness? This is a patient who's saying that reading the Headway website on brain injury was a real eye-opener for many of her symptoms.
Yes, and I think it is a type of brain injury. The one thing, there was once a test done in, it was at Columbia, and they did brain imaging, and they found a hyperactive thalamus. So the thalamus seemed like it wasn't able to gate sensory input the way it normally could. So whereas in a healthy brain, you can do more selective attention and filter out extraneous stimulation that you don't want to pay attention to. So when you have the Lyme, it seems like it causes some injury, be it permanent or temporary. And I think some of this is temporary, but some of it might be permanent. But that then results in that impaired ability with light, sound, smell, touch. It just gets an overload because it's not gated. And you can see that happen with other things that are traumatic to the brain other than Lyme disease or these infections in the body that affect the brain.
Right. And is the approach to therapy very different then if you've detected either traumatic or atraumatic brain injury as a reason for the anxiety when the patient comes
it's
to you?
similar. It's good to know, okay, your average Lyme person was usually a very active person before it happened, and that can happen with some people with traumatic brain. And so I've seen both Lyme with traumatic brain, which is a double whammy, and makes it much more difficult.
Mm-hmm.
And because the symptoms overlap quite a bit, you have to look at where your deficits are, but where your strengths are. So you're using the strengths to compensate for your weaker areas. And different kinds of traumatic brain injuries have different consequences. So it could be memory, it could be impulse control, it could be level of alertness. So then you have to do various compensations because you can't remember things like you used to, or you don't have the self-control that you used to, and then you have to do things that compensate, which you can do, but it's just like recovering from a stroke. Same logic.
Right. Do you know why COVID does seem to be causing neuropsychiatric symptoms in patients who haven't had them before if they've had a previous ME load, but it hasn't had a psychiatric manifestation? Some patients are finding that now, and we have a few questions related to that. Do you know what the mechanism is?
Well, I think there's a couple paths. One is the inflammatory effect, like the cytokine storm. But then another effect is the effect it has on coagulation, and then you can get clotting issues.
Oh, yeah.
And you can get strokes. Another is hypoxia, because a lot of people that have this can be hypoxic for an extended period of time. So it's similar to any other hypoxia injury of a drowning victim or carbon monoxide poisoning. And then that can injure certain parts of the brain. So there's memory, there's slow processing speed. impulse control issues from hypoxia. But then there's, you know, then there's, and there is evidence that you see these immune activation in the brain, even when there's no infection in the brain. Now, there are some cases where there's actually COVID infection in the brain, causing an encephalitis in the parenchyma of the brain. That's different. And, you know, we haven't really seen what's the long-term residual yet. There's also people that when they have it and they're in an ICU unit and they're isolated with stimulus deprivation, they get delirium and they're traumatized by that. And then that leaves a residual, like post-traumatic effect with that isolated delirium that they had that may go on for days. That's somewhat similar to what we see anyway with some people with ICU units, where some people get that, but this is in spades. This is much worse than what you see with a normal ICU problem. And it seems like it makes some people suicidal. We may see aggressiveness. We may see Parkinson's. We saw a lot of Parkinson's from the encephalitis lethargica, which is part of the pandemic in 1918. So we might see that with, and that can be related to hypoxia injury. So you're going to get a lot of different kinds of injuries, a lot of kinds of dysfunction from residual. And then the question is, might you see some of these injuries in people that really didn't have a bad case? That someone could have a very minimal case, not show much of the acute symptoms, but then show the residual symptoms. In some ways, like Lyme, where there's some people that do seem to get Lyme and it's a mild case. And other people, it's catastrophic. There's a big spectrum. We're seeing that with the COVID. We see that with any infectious disease. So why wouldn't we see it here?
What was that case where you saw a larger number of Parkinson's disease cases afterwards, please?
Yeah, encephalitis lethargica. In 1918, there were really two pandemics. There was encephalitis lethargica. Almost, it was like a sleeping sickness. And then there was the pandemic, the Spanish flu. So there was somewhat of a difference, and it looked like they were both going on at the same time. And it may very well have been that Hitler had encephalitis lethargica.
Oh, wow.
And if you remember, in the tail end of his life, he was shown to Parkinson's. But Parkinson's was a well-recognized consequence of that. And it's also something that you see when you see a certain incidence of that when people have hypoxia brain injury. So because of those two things, I think, and you have seen that with some of these other post-viral kind of syndromes, we may see that but that's not something you'll see a month afterwards. This may be something we'll see years from now, or it may take time to develop.
Okay, thank you. There was a cluster of 79 suicides of young people near Bridgend in South Wales just a few years ago. Is it possible that this could have been attributable to Lyme or other tick-borne diseases? Is this something you've seen over in the States or elsewhere?
Well, it could be. There was an episode. It was in upstate New York, and it was almost like what happened with the Salem witch trial, where there were like bizarre movement disorders. And then they called in the CDC, and the CDC said it was mass hysteria. But the infections, any infection, any significant infection, and this was studied, you know, I've studied it with Lyme disease and published on it. But it's also studied in Denmark, where if someone's hospitalized for an infection, you see a higher suicide rate. So any infection that of any significance that pushes you more in that pro-inflammatory state can push people more in a suicidal direction. Now, sometimes there's these suicidal epidemics where it happens sometimes in local high schools where it's almost a clustering effect. And there's a psychological part there where there's, you know, people relate to the suicide victim and copy it some. But when you see that many, you'd have to wonder, just like sometimes there's an episode of lupus in a certain area, or, you know, whenever there's a disease is excessive number in one local area, I would think of infectious disease, maybe toxicity, deficiency, but in that case, I would think of some local infectious disease first that may have never been adequately identified or treated.
Oh, wow. Yeah. We've heard from you that you've managed to actually absolve people from death sentences on death row. Could you just give us maybe one of these examples? It's so extraordinary and something one rarely ever hears, due to, I think, diagnosing them with, for example.
Well, sometimes it's hard to talk about these cases because of confidentiality issues. But for example, and I'll combine more than one, all right?
Okay.
Where you might see someone who has Lyme and might have several head injuries in addition. And then you see that they may function at a lower level. And you see, I see a number of cases that aren't necessarily death issues. And it's, and you have less of the death sentence now in most of the states.
Oh, that's true.
The things that come up are is the person competent to assist in their own defense? And sometimes the impairment is to the degree that they're not. And was it purposeful and knowing at the time? I did do the article on the Lyme and violence, and I don't want to make people think that most people with Lyme get violent. I think it's this, but it affects the brain in different ways in different people. And although I think a fair number of people have some irritability and low frustration tolerance, there's a number of impairments. It can be the intrusive symptoms, and it can be the impulse control issues. Now, the ones that would get more with the severe, where the death penalty would be considered, some of those are people that might show more the predatory aggression. Think of aggression in three ways. One is delusional psychotic depression, where, let's say, I think you're sent from the devil, and so therefore I have to protect myself. That's a psychotic delusional basis. Another is predatory aggression, where it's like stalking, and it's like there's a lack of empathy, and these you think of more like with serial killers are more like that, but not everyone becomes a serial killer. Some who have predatory aggression are caught after the first crime. And then there's impulse control disorders, and that's the most common, where someone just loses it, they get flooded with emotion, and then they do something they shouldn't do. And so each one of these we think of differently, but with Lyme, I've seen all those occur. Okay. And you can see where someone has, they shoot, and also sometimes I get the urge, whenever I see one of these family suicide, homicide, and they kill the pets as well.
Oh, no.
That's the kind of thing I see with some Lyme cases, where they say they want to kill every living thing in the house, and it just comes as like an intrusive surge. And that's more intrusive, which is a little bit different, and that's more in the impulse control category. But the predatory aggression is sometimes the hardest to understand, where if you normally, in part we're predators deep in our genes, but we have empathy and social bonding that deters us. With people that show more the predatory aggression, that doesn't work. They don't have the empathy that a normal person has. So when you go and see one of these people in one of these, like, let's say you go to death row or you go to some other correctional facility, they look at you. They don't look at you as a person the way a person otherwise would. Mm-hmm. You're more. It's almost like looking at you as an object, and there isn't. And then if you see them repeatedly, it's like they meet you for the first time every time. There's no bonding. Bonding doesn't happen. And sometimes we call Kluver-Bucy syndrome, helps us understand this, but it's a amygdala kind of dysfunction where there isn't that social connectedness. Mm-hmm. And I used to do criminal work before I ever did Lyme, and I dealt with some of these cases, including death penalty cases. And looking back, I think some of those were Lyme, but at that point in time, I wasn't thinking of Lyme. And I used to work in prison systems, evaluating some of these people. And, we can't just punish these people. Like if you say you're gonna get capital punishment if you do this, that might be a deterrent for you or I, but it's not a deterrent for these people. They don't have that capacity to have the self-control. And it is, if you go on death row and do a study, 100% of people on death row have a history of brain injury and a history of abuse. 100%. They have both. And the two together are a bad combination. Sometimes the one comes first, sometimes the other comes first. So that's someone that just doesn't process. Their brain doesn't work right the way the average person does. And I think people get a distortion because they look at these TV shows that are actors, and actors really don't show you the real sense of how these people operate.
Yeah.
And so I think if we can understand that, we could prevent a lot of this. We could prevent some of the school shootings. We could prevent some of these family homicide suicides by the earlier intervention and catching it before it goes this far. We won't prevent all of them, but I think we could reduce a lot of them in all three categories of violence.
Yeah, we need.
It's a particular concern, like places in the world where violence is endemic and these infections are endemic, and it's part of the local culture. You know, I wonder place like parts of the Middle East and Africa, where it's within the population. My hypothesis is all the brain injury related to World War I contributed to a lot of brain injured people that laid the foundation for World War II, and those people then became the leaders who then were mentally impaired that contributed to their violent tendencies and their violent behavior.
I remember you mentioning this actually in our last webinar together. Yeah. You really need to be mentoring psychiatrists and doctors across the world. Can I just mention your website, www.mentalhealthandillness.com? Could you just tell everyone here a little bit about that, how that functions and what kinds of exchanges they'll see on that?
Well, actually I don't think I've revised that for 20 years. So I have a website where I have some basic information there, but the other thing I do is I operate a list for psychiatrists who want to learn more about this. And it was over 20 years ago, I organized a meeting for us to get together and say, we're all seeing the same thing. We're seeing these problems with these Lyme patients. How can we, get together and share ideas that we're all independently figuring this out? So then after we had our meeting and we had it at the American Psychiatric Association, 1999, then we formed a group, and now there's 750 of us from 20 different countries. So the idea is it's mental health workers who want to understand the link. And it's not just Lyme, but it's looking at how does, we're particularly looking at how infections, understanding that link between infections and mental illness, and figuring out strategies for treatment and prevention, and sharing ideas and recent research so that we can improve our effectiveness with this.
That's hugely important. So we could let UK doctors and psychiatrists know that exists and link them up to you.
Yeah, any psychiatrist or psychologist, social worker, people, researchers who are interested in kind of expanding on this and sharing ideas, it's good. Now, we don't all agree, and that's good, because that way we can kind of reconcile different views.
Yeah, absolutely. Another question here is whether you treat children, and this is getting a bit personal related to your own therapy, but would you be able to Skype with people in the UK?
Well, I always insisted that I have to physically see the person first.
Mm-hmm.
And now with this pandemic, it's like, now we can't. So I've done, actually today I had an initial appointment and it was by phone. And I haven't used Skype so much, but I've done it more by phone. And the problem sometimes when they're another country is how do you work things with the meds, with legalities. And sometimes when it's done that way, usually there's a doctor there and maybe on a consultant basis. But I have treated people from other countries, and whether it be Europe or other places. And although the normal thing, they would come here and I'd see him in the office first.
Yeah, it's going to be so much harder going forward, isn't it? But I think that's fascinating to think that you could work with
In some
patients have a
ways,
doctor here. Sorry.
in some ways, the pandemic has pushed us forward in doing like this kind of a program.
Yeah.
Or doing it that way, whereas if we didn't have the pandemic, the adaptation to this new technology would have been much slower.
Absolutely.
It's held back by regulatory issues and all kinds of red tape problems.
Yeah, yeah. Perhaps there's time for just one more question before we have to finish, which is, have you heard that the suicide rate, you were talking interestingly about the SIDS rate having gone down, but has the suicide rate increased significantly since lockdown?
Well, it takes a while to gather those numbers. I've certainly heard of suicides related to lockdown, and sometimes children and teenagers. I think that's a particularly vulnerable group. And we won't know those numbers for a while, but I've heard, I've heard different places where there were increased suicides. And you don't have the formal national statistics and you won't have it for a while, but by talking to people with emergency room work, they're seeing a lot more suicide issues than they were. So I'm sure it's increasing.
Oh, yeah. Well, hopefully the next time we get to speak to you, Dr. Bransfield, we'll be out of this COVID crisis and we'll have a different world. I hope it won't be a new normal, it'll be an old normal. But also, hopefully that won't be too long. It would be wonderful to have you back again to give us your pearls of wisdom in sort of 6 to 8 weeks, if that's possible.
All right, I hope so. Although, if I look at it, like, are we going to come out of this? If you look at China first, and people question the accuracy, but it does seem like they're better in China. And then you look at Italy, and here in New Jersey, New York metropolitan area, we kind of followed Italy by 2 weeks. So now, the cases we're seeing in local hospitals here are 5% of what they were. And we're just seeing a trickle of the patients, whereas before there were a large number. And now it's hitting other parts of the country. So it seems like it's almost like a brush fire that goes through an area. And then after it's through, there's a handful of cases. Maybe there is herd immunity or something occurring, but why are and you can't attribute it all to the lockdown, because I think a lot of it blows through and the susceptible people, get it, or some get immunity and some have resistance, and then it isn't spread so rapidly. So I think we will come out of this, and I think we will kind of get back to normal, but it's kind of like what happened with 9/11 with airplane travel. Airplane travel was never the same after 9/11. And I think after this pandemic, there's a lot of procedures that are going to be changed permanently. Yeah. But I think the acute phase of it, we're going to be better with.
Yeah. Well, hopefully we will be able to travel again, and that we'll perhaps see you in person.
Yeah, that'd be nice to get back there and to be able to enjoy traveling instead of, the way when people travel, how apprehensive they are.
Yeah, exactly. Yeah. Well, thank you so much, Dr. Bransfield. That was absolutely fascinating. And we have already had several more questions come in that we'll save for sort of the next time.
Okay.
Many thanks. And thank you to everybody who was listening as well. Just to mention that on the 16th of July, that's next Thursday, we'll have Dr. Joe Jemsek back with us to answer questions on his fascinating talk a few weeks back. And so please do join us for that. That's at 5 o'clock, the same time as today. And otherwise, after that, a couple of weeks later, we'll be having a cancer series, a series on difficult issues related to cancer. Obviously, we're hoping that we won't have to continue the COVID-19 series, but we'll know sooner or later whether we do have these further waves that you've just implied, Dr. Bransfield, could occur. Hopefully not. So thank you very much, and look forward to speaking again, Dr. Bransfield. And thank you everybody who's been on.
Thank you, Jillian, and goodbye to everybody.
Bye-bye. Thank you.